Maybe let's dive in a little bit deeper into the provider experience and talk about that. That's kind of what we want our first conversation to be about. And then we'll be talking more about patients a little bit later. But just for some further introduction, just to kick us off, we're going to have Dr. Matt Bouchonville give us a little bit of a talk about Project ECHO and the role a model like Project ECHO can play in all of this. Dr. Bouchonville is an associate professor at the University of New Mexico School of Medicine in the Division of Endocrinology, Diabetes, and Metabolism, and serves as medical director of the UNM Diabetes Comprehensive Care Center and the UNM Center for Diabetes and Nutrition Education, and the Endocrinology Tele-ECHO and the Endo-ECHO program at the Endo Institute. So yeah, a lot of insights from Project ECHO and from kind of the beyond the oncology space as well. So I think lots for us to learn. Here you go.
All right, thank you. So I'm Matt Bouchonville, and do I just hit this arrow to advance? Great. And I'll be talking to you about a different way of practicing healthcare. It's called Project ECHO, and yeah, I'll specifically be speaking to the provider experience. No conflicts of interest. And just for a brief background, I want to show a picture of New Mexico here to make the point that it's a very large rural state, and that's part of the reason why Project ECHO was started in New Mexico to begin with. And what we're looking at here is actually a picture of Albuquerque at the base of the mountains. Albuquerque sits at about 5,000 feet, and then the Sandia Mountains sit about 5,000 feet above Albuquerque. And if there's any Breaking Bad fans in here, the images that might come to mind when you think of Albuquerque would be Winnebagos and chemistry. But as a healthcare provider, what comes to mind when I think of New Mexico is that it's a very medically underserved region. So HRSA has actually designated 30 of our 33 counties as being medically underserved. So access to care is a big problem in New Mexico. And so, in fact, when we were doing a needs assessment about 5 or 6 years ago from an endocrinology standpoint, we were looking at counties in New Mexico that actually had an endocrinologist in them. And really, it was just a handful of counties. And most of those were centered around the county in the middle there where UNM is. It's the referral center for the state. And in contrast, if we look at where just the type 1 diabetes, those are the autoimmune diabetes, referrals were coming from just over the course of a year. You can see they're really coming from all over the map. And the same is true of type 2 diabetes. And these are the patients who could actually afford to take a day off of work and travel 5 hours to get to UNM, 5 hours to get back, or come the day before and stay a night, you know. And you can imagine that we were pretty overwhelmed in the endocrinology clinic as a result of this. So for a new referral to the endocrinology clinic, and endocrinology, it's mostly diabetes, it's really a specialty of hormones, thyroid and so forth, mostly diabetes though. So for a new referral to the endocrinology clinic at this time, the wait time for a patient was about 13 months, so over a year for a patient to get in. And sadly, this is not a problem that's unique to New Mexico. So same kind of picture with endocrinology that Dr. Schwartzberg was sharing with us with respect to oncology. And so what does this mean for patients with complex diabetes on insulin pumps and so forth? It means that really the brunt of care is falling on the primary care workforce. And not all primary care providers feel equipped to manage complex diabetes or other endocrine conditions. So in this specific survey, PCP cited a lack of confidence or adequate training as being like barriers to providing optimal diabetes care. But PCPs also recognize that there's a major barrier to getting patients into an endocrinology clinic. So when asked about what a solution might be, they reported that case coaching and a multidisciplinary collaboration could potentially overcome these barriers. And that's a very important point to make there because that's essentially what Project ECHO is. So I mentioned during the introductions that it's really a telementoring program. And so if you think about, and we just heard a great presentation on all the different forms of telehealth, but this is just the traditional kind of telemedicine model that we think of. It's a very effective means for bridging a geographic barrier and has been very effective in diabetes in particular. What ECHO does though is kind of expand on this fundamental unit. So in the traditional telemedicine model, there's a specialist connecting with a patient remotely, but her wait list continues to grow. She's got a 13-month wait list to get into her clinic. So it's not necessarily capacity building while it does bridge geographic barriers. So what the ECHO model does is it's kind of a workforce development model. So you're actually building new expertise, building new capacity. It's a telementoring program. So on one end, you've got a team of specialists, and on the other end, there's not patients that are tuning in. It's actually primary care providers and other healthcare professionals. And they're meeting, this is a kind of an ongoing mentorship. I'm going to show you a picture on the next slide, but they're meeting regularly in these like virtual kind of clinic spaces via video conferencing technology. And over time, and I'll show you what this looks like, new expertise is being built in the primary care workforce so that more providers are able to do more for more patients. They're the end beneficiary. So it's really a force multiplier effect. And so here's what one of these sessions look like. We call these echo sessions or tele-echo sessions. So they're really like a virtual clinic. So and we use Zoom technology. And so on the right side, we've got a team of specialists at Project Echo. They don't even necessarily need to be in the same room together. We could have people tuning in from different parts of the country or from their office at the hospital, wherever. But if you think about a hub and spoke kind of model, at the hub on the right there, you've got a team of specialists. And then the spokes of this hub and spoke model would be the people tuning in from medically underserved communities. In this case, these were mostly community health workers and primary care clinicians tuning in. This is actually our clinic. We call it Endo Echo. And ours is a weekly session from 12 to 2 every Wednesday. Some of these are every 2 weeks, depend on like other people's echoes. Some will have an echo maybe every once a month. And they're really framed around case-based learning. So the kind of learning that we use in residency programs and fellowship programs. It's a very engaging form of teaching. So essentially what happens is these clinicians on the network, and we can all see each other. It's kind of like Hollywood Squares with all the tiles. It's very collaborative. So they will actually present a de-identified patient over the network. And then we'll do a round of clarifying questions. So their peers on the network will ask for clarification. We'll ask for clarification. And then we'll do a round of recommendations. And it always starts with their peers on the network, because over time they develop expertise and they're actually able to give recommendations themselves. That's really the bulk of the sessions. For about 15 minutes per session, we'll have a best practices didactic as well, so that we have kind of a formal curriculum. And those are really developed around clinical practice guidelines. So for our Endo Echo, that's usually going to be ADA guidelines or the ATA guidelines for thyroid, et cetera. And so that's what an echo session looks like. I mentioned that echo started in New Mexico. It actually started with hepatitis C treatment. And it was started by Dr. Sanjeev Arora. He's a gastroenterologist. And he published his experience in the New England Journal of Medicine, demonstrating kind of proof of concept that the model does work. It's safe, it's effective, and it's also very cost effective because you're not moving patients, you're moving knowledge. We call it a democratizing of knowledge. So as a result of this published experience, the ECHO model has really taken off. It's now all over the world. It's being applied to over 100 complex conditions and has been adopted by over 250 centers worldwide. And so all of these red circles here, these aren't the spokes, these are just the hubs. If you plotted the spokes on here too, it'd be even more widespread, as you can imagine. But the point I want to make here is that most of these are academic medical centers. Several of these are sponsored by an advocacy group. So American Academy of Pediatrics has their own ECHO, American Cancer Society. We are currently in talks with the American Diabetes Association to work on a collaborative ADA ECHO that will kind of work with us and then some of our partners that have replicated and started their own endo echoes around the country. And some of these echoes, I bring this up because I think of immuno-oncology as being highly specialized, but some of these echoes, instead of the spokes being primary care clinicians, they're actually specialists And the hub is like a nationally recognized leader in the field who writes the guidelines. I think of Bone Health Echo, I participate in that one, and Mike Lewicki, who writes the osteoporosis guidelines, leads that echo. So some of these are kind of like super echoes that are building up the specialists. So you can kind of get the feel from this map that you can use the echo model to really rapidly disseminate best practices as new science emerges. And so how has our experience been? I'm going to speak more to the provider experience now in New Mexico with our Endo Echo pilot program. So we just wrapped up a 4-year pilot program really aimed at improving capacity for care of patients with complex diabetes in New Mexico. And so we built recruited from UNM, essentially, a multidisciplinary team of experts. And so, again, just kind of emphasizing the team-based approach here. Everyone that we thought would be important to be involved in the care of a patient with diabetes who's being presented over the network. So a behavioral health specialist, endocrinology, educators, and so forth. And so that was the hub. And then at the spokes, we partnered with 10 federally qualified health centers around the state and identified a primary care clinician and a community health worker with interest in building up their expertise in complex diabetes management. And for the purposes of the study for this pilot program, we formally partnered with these centers, but echo sessions are free for anyone to tune into. So in addition to these people who were part of the study, and we were tracking like patient outcomes and so forth, we routinely have people just tuning in from anywhere in the state or the country that want to participate. And so, as I mentioned earlier, these sessions are really built around case presentations. And so the point of this slide is to show that most of the presentations that were presented over the 4-year program were really around diabetes care, type 2 diabetes and type 1 diabetes, followed by thyroid disorders as the second most common kind of condition, and then a number of other endocrine conditions that are encountered commonly in the primary care setting. And then I alluded to the fact that for a short set part of each session, there's a didactic, just so we can follow along a best practices curriculum as well. And this is just an example of what that looks like. We kind of broke it down into blocks. So like a motivational interviewing block, integrative medicine block, metabolic surgery block, etc. But really the sessions are built around case presentations more so than didactics. We want to get away from these turning into like a webinar. Just to keep it more engaging. All right, so what impact has this had on network participants? I'm on my last couple slides here. So, and specifically, I'm gonna speak to the primary care clinicians that we partnered with. So one thing that we found is that they were more confident after participating in ECHO. So self-efficacy improved significantly across the primary care providers that were involved in EndoEcho. They were also more likely to adopt best practices. For the purposes of this survey, we were looking at like ADA best practices. Again, making the point that ECHO is an effective way of disseminating best practices as new science emerges. We were really excited about this, that primary care clinicians participating in these weekly ECHO sessions were less likely to need to refer patients out to see a specialist. On the flip side of that, for the patients that these participating PCPs saw that they felt like really needed to see an endocrinologist urgently, they reported that access was drastically streamlined. And that, as an endocrinologist, that's a big benefit of the ECHO model, is that you could consider ECHO as a really efficient means of triaging a large geographic area and figuring out, kind of filtering out these patients that you probably need to see in your clinic within the next week or two from the really large base, actually, that can be appropriately managed collaboratively via the ECHO model. And then this was exciting too. These are PAs and nurse practitioners that we're building up through the ECHO model, and they're reporting that they're starting to get referrals from MDs in their community with complex diabetes and thyroid disorders, as if they're the local expert. And that's really the goal of ECHO, is to kind of set up these satellites around the state in these medically underserved regions. And so those are kind of the take-home points in terms of the provider experience. But just overall, in summary, with the ECHO model, we've built up our primary care workforce in New Mexico to treat complex diabetes and essentially empower them to treat patients who they previously would have referred out for care. So patients are now getting the care that they need in the communities where they live. And we believe that this is improving diabetes care in our state. And I do want to acknowledge the Helmsley Charitable Trust who supported this 4-year pilot program. And happy to take any questions.